So much. Thank you all for having me. It's a great honor and a pleasure to be here. I'm hoping it's an interesting topic that interests people and hopefully stimulates a little discussion afterwards. So I'll just jump right into things. I have no disclosures related to this talk, but here are my just general disclosures. The outline of the format I'd like to follow, and I'm hoping this works for everybody. I want to first talk about the organization of how we think about bone tumors in terms of like what our brains are thinking about, what my brain is thinking about when I'm looking at an X-ray or imaging. And then we'll sort of go into a little bit some of the topics, discussion on some of the common benign bone and malignant bone tumors, and then similarly common benign and malignant cartilage tumors. And then I want to hopefully finish up with metastatic disease because it's an area that I often think does not get enough attention. And then at the very end, we'll hopefully have some time to talk about creative ways to reconstruct bone defects, because I think that that's an area where in orthopedic oncology, I tend to be the MacGyvers and come up with interesting things to do in those settings. So I'm going to start by showing this slightly busy slide, and I'm going to come back to it a few times in this talk because it's sort of the way I tell my residents and I tell colleagues of mine to think about the way to look at a bone tumor or a lesion in the bone. So we start out with a lesion in the bone, and the first thing that I like to ask myself is this lesion making bone or taking bone away? So is it mineralized or is it non-mineralized? And mineralized includes the cartilage area, even though it's not really bone. But that's how I like to think of them. And then between that, you can then separate what your plan is, because the mineralized ones generally have a matrix. It makes it a little bit easier to diagnose them, in my opinion, based on plain radiographs. And then you can make an easier plan for the patient. The lytic ones we're going to talk about because they can be a little bit more of a diagnostic challenge. The other thing that we have to think about in the realm of tumors is age. Unfortunately, in our world in orthopedic oncology, we think of anybody under the age of 40. I say unfortunately because I'm in the old person category at this point in my life. I'm very sad about that, but it's okay. Um, we think of people in the young age as being usually under 40. Sometimes people say under 50, and older patients being those under over 40. And this just helps us characterize the aging, because that plays a big role in our diagnostic differential that we're going to create for the patient. And the other thing I have to mention when we're talking about these types of tumors, lesions in the bone, is that location is really important. So when we talk about lesions in the bone, I say this to my residents all the time. If you call me up for the consult in the middle of the night, or you're on call and you have a concern, please make sure you're telling me, is it metaphyseal, diaphyseal, epiphyseal? And in what way is it a long bone or flat bone? Those are things I want to hear about, because those will shift our differential diagnosis in different directions depending on that. Dr. Enekine is one of the fathers of orthopedic oncology, or maybe even grandfather, great grandfather nowadays. And he used to have this kind of teaching method, and it is actually very effective. We still use it to this day. He talks about these things questions you should be asking yourself when you're looking at an X-ray, and we're going to do that throughout this talk. But I just want to remind people, if they haven't heard it recently, that this is sort of those questions. Where is the lesion in the bone? We just talked about location. What is the lesion doing to the bone, and what is the bone doing to the lesion? So I'm going to show you some examples of that, where you can hopefully ask yourself that question and hopefully get to a diagnosis based on that question. And then finally, is there a matrix? As we just talked about, if there's something being mineralized, there's a matrix, and that can help us decide in what direction we are looking at. So back to this slightly busy slide. We've talked about the fact there's a lesion in the bone. We're going to go down the pathway for the moment of a mineralized bone lesion that happens to be making bone. And we're going to come back to these other ones in just a minute. So let's talk about that. There's two categories of making bone in a person. There's good bone and there's bad bone, basically. And in the case of good bone, this is an example of extra bone being made on an X-ray. Hopefully you guys can see an apian lateral of the distal femur and knee region. And on that, particularly on the lateral, which is probably the easiest one to see it in, you can see that extra bone is being made that normally wouldn't be there in the average person that you get an X-ray like this in. But we know this is good bone, not cancer bone. What I mean by that? Because the bone itself is very smoothly being laid down. It's very uniform. It's very symmetric. It is not chaotic. It is not haphazard. So we know, just looking at this X-ray alone, that this is good bone. And actually, in this particular case, you can actually see a little lytic area in the middle of it, likely representing the nidus. So we also know this is an osteoid osteoma, which is a benign bone tumor in a young person that can be treated very easily. with radiofrequency ablation or curettage, and it is good bone. It is not a cancer or anything bad. In your differential for the same type of lesion, you'd have osteomyelitis and you could have a stress fracture. Those would all be examples of uniform good bone that would look similar to this on imaging, on just plain x-rays. And most of the things, by the way, that I'm going to talk about today, the diagnosis can come from just plain imaging, but and then sometimes with a biopsy because we have to. So this is an example of bad bone, right? Hopefully most of the folks who are looking at this can see that this is chaotic looking. The bone is extending well outside the borders of the normal periosteum. And we can see that there's bone on both sides, on the inside and the outside, the lateral side and the medial side of the bone. And it looks chaotic and destructive. So this is an example of bad bone. And most of the more senior people probably looking at this can say immediately that this is an osteosarcoma. And that's because we recognize that in a young person with bad bone formation taking place in their bones, it's an osteosarcoma until proven otherwise. And so that is pretty much the only thing that this could be. Now, I just made it seem like there's only good bone and bad bone and there's nothing in between. And the reality of it is that there can be situations where the imaging looks a little bit chaotic and not necessarily is a bad thing, and vice versa. Sometimes you can have situations where it doesn't look so bad, in rare situations where biopsy confirms something a little bit more serious. Paget's disease of bone is one of those examples of something that can look a little bit in between. But if you look carefully at this bone, what you can see is that there is, even though it looks chaotic, there are some telltale signs, or what we call pathognomonic signs, that this is not bad bone. And that's because we can see that the trabeculae are really nicely thickened as we'd expect them to be they're matching the distribution of normal trabecular architecture in the bone. We can see the thickening of the cortex, but again, it's thickened in a very uniform way. And then there's this final telltale sign on this imaging on the right, which people talk about either a blade of grass. So you see this little or flame. I actually think it looks a little bit like a sword kind of cutting through the bone. Any of those names are fine, but what you do have to recognize is that when you see this, it's almost pathognomonic of Paget's disease of bone and not something bad or something serious. So there can be things in the middle, but oftentimes those middle things have some telltale features that can help us make the diagnosis. So we talked already about osteoid osteomas as one of the more common benign bone forming lesions. The other ones that are in that differential are fractures and osteomyelitis that can also look like that, but may have some other different features. Then you've got bone islands, which we're about to talk about in Paget's disease. These are the three main types of benign bone forming lesions that most people who are treating patients in the orthopedic world need to know about. There are some other esoteric things out there that are out there, but those aren't the things that are going to get you hung up. These are things you really need to know to be a good practicing orthopedic surgeon. So bone island, which is the only one we haven't shown yet. Bone islands are sort of interesting. I'm showing you an MRI and CT scan, but to be perfectly honest with you, I usually don't do these types of images for bone islands. I usually just do plain x-rays. And but the problem is a lot of times the reason patients are coming to see us or being referred to the orthopedic surgeon with their bone island is because somebody already got a CT scan or an MRI for some other reason and they happen to discover this. But what you're going to see is that it's just a piece of what looks like cortical bone sort of sitting in the middle of the medullary space, not causing destruction. So this is an example of where you ask yourself the question, what's this lesion doing to the bone? Not much, right? It's not destroying the cortex. It's not just involving any area that is causing a trauma or damage. And the bone's doing nothing to it. There's no periosteal reaction. There's no surrounding edema or other findings that would worry us. So we can safely say this is a bone island based on these images. If for some reason you had a patient with a history of breast cancer or prostate cancer, and you found one of these and you were worried about the possibility of metastatic disease, I usually get a bone scan because bone islands should not have uptake on bone scans, generally speaking. So that would be the next step in terms of testing if you really felt that you had to confirm a diagnosis. So now let's talk about bad bone. The good news about bad bone is from a diagnostic standpoint, there's two types of bad bone. There's either osteosarcoma or metastatic disease, and that's pretty much it. And It's one of the dilemmas that can happen if obviously on the left-hand side of your screen you're staring at an osteosarcoma, on the right-hand side you're staring at a metastatic case of metastatic disease with multiple vertebral body involvement with lots of sclerotic bone formation taking place. Both pictures show chaotic, um, abnormal bone that just you look at those images and you see chaos, and that makes you unhappy. It should make you unhappy. You should have little sad faces right now staring at these images. But there are some ways that we can help figure out, distinguish between the difference. So we often think of osteosarcoma, and I'm gonna delve into that for a minute, as being a young person's cancer. But I want you to be careful about that thinking. If you look at this graph, I'm sure people have seen this before, but there are two main peaks when osteosarcoma is common in life. And one is in the early ages, that's the biggest peak. And then the other is later in life. And so you have to be cognizant and aware of the fact that osteosarcoma can show up in 50, 60, 70, and 80-year-olds. Often they're secondary cancers from previous radiation, Paget's disease, etc., but that's real. So the dilemma can be that you ignore the patient who's 80 years old with a new osteosarcoma, which can get you into some serious trouble. Or you treat it like metastatic disease, which would obviously, again, get you into some serious trouble, as we'll talk about. So there are several different types of osteosarcoma. I'm just going to delve into this because it's such an important topic for a few minutes. But I don't think it's important for people to know, unless you're an orthopedic oncologist like myself, I don't think it's so important that you have memorized the different subtypes of osteosarcoma. That's not going to fare you very well if you're a sports medicine doctor or a general orthopedic surgeon practicing out there in the world. But you do need to know a couple important things. You need to know there's more than one variant of osteosarcoma. Whether you know the names is doesn't matter. And there is a variant, two variants that actually show up as lytic, meaning they're not, oftentimes on the imaging, they're not necessarily forming bone. So this is an example on the right-hand side of your screen of a telangiectatic osteogenic sarcoma. So they can be lytic and they can fool you because they can look like a giant cell tumor bone or an aneurysmal bone cyst or something like that. So you just have to be aware of the fact that these exist, and these are important. That's why you don't jump to conclusions about lytic lesions, as we'll talk about soon, but that's just important to recognize. So my general workup for osteosarcoma, if I've got a patient that I suspect has an osteosarcoma, of course, we're going to do an MRI of their entire bone that's involved. So if it's the femur, it's got to be an MRI of the whole femur. We often still do whole body bone scans, in this case, to look for sites of metastatic bone disease, and a chest CT. You do not need a CT of the abdomen and pelvis. That's an unnecessary test for these patients because osteosarcoma will not metastasize to the abdomen and pelvis without first going to the lungs and bones and other sites. And then, of course, you got to make sure, I always tell the residents this, that you have good plain x-rays, including the joint above and below the bone involved. And then, of course, in our case, we often will do then a needle biopsy or some type of biopsy to get a definitive diagnosis, even though oftentimes on imaging you have an answer, but most people do a biopsy. And then in terms of treatment, I think most people know this, but it's important to know that these patients are going to get chemotherapy. Usually they're getting chemotherapy before surgery, so they're going to get a couple rounds of chemotherapy before they actually move to surgery. Exceptions to that are some of the low-grade osteosarcomas that can go straight to surgery a lot of times. And then we're going to proceed with the surgical wide resection, as we're going to talk about in a second. There's no role for radiation in the treatment of osteosarcoma for the most part. And so that's not something that should be in your kind of repertoire for when you're talking about treatment of osteosarcoma. Here's an example of a 22-year-old female that we treated in the past with a mass growing in her knee for several years, unfortunately, with a decreased range of motion persistently happening slowly over time. We can look at these x-rays and hopefully you can see, like we talked about, with that's chaotic or non-chaotic bone. This is chaotic bone. We've got bone that's both in the medullary space and in the soft tissue. It's not well defined. I can't draw an easy line around where the start and finish of that bone is. So this is chaotic and this is bad bone. So we know this is an osteosarcoma, and it probably started out as a low-grade paraosteal, but by the time we biopsied it was high grade. So she probably had dedifferentiation because they'd been there a while, unfortunately. So what are we doing for a case like this? In my institution and in my hands, in most cases, we're going to do something along these lines. We're going to do some sort of distal femoral replacement and reconstruction. So she's going to get a hinged knee replacement, essentially. This gets people up and moving relatively quickly, gets them back on their chemo relatively quickly, within a few weeks, hopefully, if everything goes as planned. and allows them to maintain their limb. We can't always do this. Sometimes if there's vessel involvement or nerve involvement, we have to be thinking about amputations and other types of things like that. And I point out that the stem fixation, obviously here we used press fit, and then that's what I tend to use, but I don't think that matters as much. You do want to, whatever you use, you want to be comfortable with this. So if you're somebody that is a cement guru, then cement might be the way you go. If you're somebody that's a press fit guru, or that's what the implant that's available to you is, then that's probably what you're going to use. So I think that that's less important, but reconstructing the knee joint, of course, is important for getting the patient back to good function. So we don't always use big mega crazy prostheses. I actually think that there are that the use of those probably are a little bit, we do them a little bit too much in the United States, and that can have some consequences long term, because in the knee you have no choice, but in other parts of the body you do have choices on the type of reconstruction you're going to do. And so I think we should be careful about just getting stuck with only using implants as our options for treatment. And sometimes we don't have implants available, quite frankly. This was a 9-year-old female who presented with a lesion in her proximal humerus, initially seen in the emergency department, and unfortunately the emergency radiology team initially diagnosed it as a unicameral bone cyst. And so there was a delay for her getting to see me in the office because the team did not recognize the seriousness of it. And then, of course, a few weeks later, she shows up in the office, and the x-rays are looking like this. And biopsy confirmed the presence of a telangiectatic osteogenic sarcoma of the left proximal humerus. She's young. She's going to continue to grow. We're going to be doing a fairly extensive resection, and we have a bunch of options. You can put a metal implant in. You can put a shoulder arthroplasty of some kind in. You can also do an allograft. You can do an allograft prosthetic composite. So these are all options that are available to us. But we actually chose a different route in her case. We actually chose to harvest her fibula. Because of her young age and her potential to grow, and because we didn't want to put an artificial implant in her. That was her preference. We harvested her fibula with the vascular supply to the growth plate still intact. This is a tedious surgery, not an easy one. I don't do this alone. This is done with my plastic surgery colleagues. They're doing this part while I'm doing the surgical resection of the tumor proximally. And their part actually took longer than my part because of the tediousness of dissecting out that perineal nerve and trying to spare some of those branches while they're trying to harvest that fibula. But then we can transport it up and place it into her shoulder. And then this is on the right is the most recent x-ray. She's now 18 months out from this surgery. And we've confirmed that the fibula is actually continuing to grow in that proximal humerus. Her function's okay. It's not great, as you can probably imagine. Whenever you detach all the tissues of the shoulder and then try to reattach them, they're never perfect. But she gets about 45 degrees of forward flexion and abduction. And more importantly, she can position her arm in space and use her hand and elbow totally normally. And so functionally, we're happy with this outcome. And this is a way of not having to use a big allograft or some other expensive implant in a young person who's still growing and has potential to keep growing over time. So those are kind of the gist of the mineralized good and bad bone tumors. I'm going to shift now to talk about cartilage tumors and the good and bad in that category. So there's two types of cartilage tumors, really, which are the benign ones and the malignant ones. And the good news for purposes of education, the malignant ones all fit into one category. There's only one type of malignant cartilage tumor, and that's chondrosarcoma. There are subtypes, much like we talked about with osteosarcoma. There are subtypes of chondrosarcomas. But the main thing to know is that there's one major type, which is chondrosarcoma, and then there's these subtypes. And again, I don't think it's important for the average treating orthopedic surgeon to know all the subtypes, but just to know that there are different variants out there is probably important. And we're going to talk for a few minutes first about the benign tumors, some of the more common benign tumors that we're going to see, because we want to obviously distinguish them from the bad ones, because their treatment usually doesn't require major involvement with us. So enchondromas are the most common thing that you're going to see in your orthopedic practice. If you're a shoulder surgeon, you're going to get like 50 of these a year. You're going to get x-rays for the rotator cuff tear or for the rotator cuff or the osteoarthritis that's in that shoulder, and you're going to see an enchondroma sitting there, and you're going to wonder, do I need to do anything about this? And you're going to go back to that Enneking questions. You're going to say to yourself, what's this thing doing to the bone? And if we look at this thing, we see the classic popcorn appearance. You'll hear people talk about popcorn in the bone. That's kind of a way of saying we're talking about something that's cartilage based. or rings and stipples. It almost looks like somebody took a pencil and dotted little dots and circles in the area. So that's an example of a cartilage-based lesion. And in this case, this cartilage-based lesion is sitting comfortably in the bone. There's no endosteal scalloping. We actually are okay with a little endosteal scalloping in enchondromas. There's no periosteal reaction. There's no cortical destruction. There's no evidence that this is reacting to the lesion in question. So we know this is an enchondroma. It does not require a biopsy. You can see the pathology on the other side here, just for the purposes of people knowing what it looks like, particularly for the residents out there. That it is blue cartilage looking in stuck in the marrow space and very happily doing nothing at all but hanging out there. You do not need to biopsy this. You do not need to surgically remove this. You do not need to do anything further with this, except I usually recommend follow-up imaging a year later just to make sure that it is stable and unchanged. And then I don't think further follow-up is warranted for most of these, unless there's some change. I do warn people that enchondromas can look more aggressive in the hand. So for those who get hand x-rays and see a lytic lesion and you get a little bit nervous, like this is expanding the cortex, there's some endosteal scalloping, is this cancer? What I tell people is that an enchondroma can look very aggressive in the hand. Unless it's breaking through the bone and extending extensively into the soft tissue or causing serious cortical destruction, it is still an enchondroma, not chondrosarcoma, okay? The other really common cartilage tumor that you're going to see in real life and in your practice as orthopedic surgeons is osteochondromas. You're going to see them if you're taking care of pediatric patients, you're going to see them if you're taking care of adult patients, you're going to see them. They're just so common that it's hard not to see them. I put them in the category of cartilage tumors because their origin is this cartilage cap, even though a lot of people think of them as bone tumors because there's bone that's being made by that cartilage cap. But at the end of the day, it's the cartilage cap that's creating the bone. So I put it in the cartilage category. But you're going to see this very pathognomonic finding on imaging, which is this broccoli stalk that has continuity with the medullary space of the patient and usually facing away from the joint. And it has unlike that periosteal juxtacortical osteosarcoma we saw earlier, it's not chaotic looking. It's very well defined. We can draw a clear line around it very easily, and it's not causing any harm. And the good news is in 99% of osteochondromas, you do not have to do any treatment at all for these. I rarely treat these. I will say there's always some patients that come in that need them removed because of pain or discomfort in association with them, but that's a very small minority. The vast majority of patients aren't having major symptoms and we don't have to do anything for them. Chondroblastoma is one of the cartilage tumors I like to talk about because it's a little bit more common than some of these other more esoteric ones. If you're taking care of pediatric patients or you're doing younger sports medicine, you're probably going to see them at some point in the knee or in the shoulder. They are lytic, unlike the other cartilage tumors that I just showed you, where we have some sort of matrix to go off of to help us with the diagnosis. Chondroblastomas generally have less of a matrix. They sometimes will have some mineralization in them that help you, but they're often lytic. They're in the epiphysis. That is their pathognomonic location is the epiphysis of the bone in usually a young person. And so if you see an epiphyseal lesion in a young person, chondroblastoma should be at the top of your differential. So I show you that because it is one of those ones that comes up. And I see probably 3 or 4 of these a year in my practice, usually referred over for my sports medicine colleagues because they're taking care of a young person who's got ongoing pain and they can't figure it out. They get some x-rays and they see a lesion such as this. So now let's talk a little bit about the one that's the more challenging, the more serious one, which is chondrosarcoma. So we talked about the rings and stipples in the bone being a telltale sign of a cartilage lesion, and the same still holds true for most chondrosarcomas. We will see this popcorn-looking appearance in the bone, but the difference is we now have, when we ask ourselves the question of what is this thing doing to the bone and what is the bone doing to it, we can answer that this thing is doing something to the bone, right? The bone it's percolating through the bone. It's caused a pathologic fracture on the left-hand side. It's destroyed the cortex on the right-hand side. So it is doing something bad to the bone. And more importantly, the bone is trying desperately to wall this thing off and get it under control. So you see this immense cortical thickening around these rings and stipples or popcorn. And we know this can be nothing else but a chondrosarcoma. So both of these are examples of a high-grade chondrosarcoma. Chondrosarcoma can be on the surface or in the center of the bone, in the medullary spaces I just showed you. These surface chondrosarcomas still have that matrix. So they still look like popcorn, rings and stipples or big popcorn. worn in the bone, but the difference being now it's now extending from a flat bone of the body into the soft tissue. So the surface chondrosarcomas tend to involve the flat bones more so. So your pelvis, your sacrum, your ribs, your sternum, and your scapula are the most common spots for a surface chondrosarcoma to appear. So rings and stipples, soft tissue or in the bone, think cartilage. But be careful, beware of the mimickers. So here's some what we would probably call rings and stipples in soft tissue. But the interesting thing about this is we can see that this is very well defined within the joint space, right? It's matching the anatomic location we'd expect to see for a capsule of a proximal shoulder joint. And when if we were to get cross-sectional imaging, so in this case, I might get a CT scan or an MRI to look at this, just to confirm what I'm already suspicious of, which is that this is synovial chondromatosis. But I will find that there's no continuity with these spicules or clumps of cartilage with the bone itself, and that confirms the diagnosis at that point. And you don't usually need anything further to go from there. So the workup for chondrosarcoma, obviously the same thing, similar to osteosarcoma, you get a whole bone X-ray, a joint above, joint below, MRI of the whole bone. Bone scan can be helpful because chondrosarcoma can spread to other bones, and then chest imaging, usually a chest CT again is the way to go. I put question marks next to biopsy because there's some debate, at least here in the United States, about whether a biopsy is necessary for some of these more obvious chondrosarcomas like this. Do you really need to biopsy this to know it's a chondrosarcoma? Probably not. You probably could skip the biopsy and move straight to planning a surgical plan. I have to admit, at our institution, we still do needle biopsies, even in those cases, because of more for medical legal reasons. We're just a little more nervous. We have a high rate in the United States of lawsuits, and so we're kind of protecting ourselves. But I think you would not be faulted for not doing a biopsy if you have a very clear, obvious diagnosis in the case of chondrosarcoma. So treatment of chondrosarcoma, the good news is, and the bad news is that it is a surgical disease. It is not one that has a medical treatment paradigm or medical treatment modality. So chemotherapy and radiation therapy play no role in treatment of chondrosarcoma. It means that you as the surgeon are the person who is in charge of making sure this patient survives their cancer. And so it's a surgical disease, and so you have to be very careful about the surgical planning. You really want to do a good job of doing a wide resection. This is an example of a young person. She's a school teacher who presented during COVID. It was right in actually it was March of 2020, with this lesion. Biopsy confirmed the presence of a chondrosarcoma. We had some cross-sectional image, which I didn't include here, but the tumor flops over the joint, but doesn't actually extend into the joint. She's got a good joint capsule protecting her joint, but the tumor extended right up to just the superior dome of the acetabulum. So we knew we'd be cutting right through that superior dome of the acetabulum and taking this portion of the pelvis. So the question becomes, what can we do from a reconstructive standpoint for this? You got a lot of options, actually. This is what we ended up doing. We were trying to save her joint. She is young. She is somebody who wants to go to work and still live her life. So we tried very hard to save the joint, which we were able to do. This is an allograft that we placed in there to actually span that space between her pelvis. And you didn't necessarily have to use an allograft. That's just what I chose to use for this particular case because it was available to me. But other things we could have done, could have cut this extra piece of bone from the iliac wing up here and flipped it down and used that instead, or we could have used a double barrel vascularized fibula. All of those would have been acceptable options and would have probably had the same outcome. This was what we ended up doing. And actually we were hoping that her hip would be okay. And surprisingly, this is her 5 years later now. She still follows up with us and she's doing well, no recurrence of disease, but she formed a pseudo acetabulum from that allograft and from the residual bone that we left behind. And she walks now very reasonable. She uses a cane for longer distances and she has to take her time going up and down stairs, but she's able to return to work. She's back being a functional member of society. So I would consider this a very good success without having to do a lot of crazy reconstruction for her in this case. So now we're going to talk about the final area that I think is really important here, which is lytic bone lesions or non-mineralized bone lesions. When again we go back to Dr. Enikin and he kind of broke them down for us into three types. There is type 1, which is inactive, type 2, which is active, and type 3, which is aggressive. And we're going to talk about each of those. In the inactive category, the good news is, generally speaking, these are all benign. So that's number one. Inactive tumors, benign. You don't have to do a further workup on these inactive lesions, and you don't have to biopsy them. You can leave them alone, particularly if they're not causing any problems. It's the active and the aggressive lytic lesions that are problematic because, and I'll show you some examples, because we don't necessarily have a matrix to go off of, so we're not necessarily certain of the diagnosis, and they can be anything from a benign tumor like a giant cell tumor of bone or an aneurysmal bone cyst or a UBC to something more serious like a Ewing sarcoma or telangiectatic osteogenic sarcoma. So these guys actually represent a lot of diagnostic dilemma. So these are our three different types. On the left-hand side, you see something that has a very well-defined sclerotic border, and I can almost take a pencil and draw around the edges of this thing very clearly and mark out that sclerotic border. So this is an inactive lesion. It has a well-defined sclerotic border. It's been there a long time for the patient. This is an example of a non-ossifying fibroma in a young person and does not need further workup or treatment. It can just be followed and monitored. In the middle, we have an example of a type 2 or active lesion. There's no sclerotic border. That sclerotic border is not present, but I can still take a pencil and kind of draw the main outline of the tumor. I can still see it. It's not breaking through the cortex at this point. There's not some big soft tissue extension. And then, of course, we go to the far right-hand side, and you see that you've got what's called an aggressive tumor. There's no cortex on that lateral surface anymore. Your borders are all over the place. You can try your best to try to get a clear border, but you're not really going to find a very obvious border to this tumor. And that's an aggressive tumor. And those are the ones, of course, that you have to be very worried about more serious tumors in, like osteogenic sarcomas and like lymphomas and other bad players. So this was a 15-year-old male who presented to our office several years ago with this lesion. And so I would characterize this as aggressive. There's no longer a laterally based cortex of this tibia. The bone's at risk of fracture in this particular case. The medial border is fuzzy, I would call it. I'd say it's not a clear, it's a wide transitional border. So you don't have a clear demarcation of this lesion. So we're going to do a further workup. It's not in the inactive category. Something needs to be done about this. If it was inactive, you do nothing. In our case, I get further imaging only because it helps me a little bit with the diagnosis. And in this case, it did help me hone down my diagnosis, although not to completely give me an answer. And it also helps with the biopsy, because if I'm going to do a biopsy, it helps me to know whether I'm going to do an open or a needle biopsy based on sometimes the imaging. If there's a big area of necrosis, I might try to have our radiology team make the needle track go in the direction that we want it to go in, or maybe I'm going to do an open biopsy because that's going to give me more solid tissue to work with. So next steps. What did we do? We did a biopsy. And in this case, if the biopsy results came back looking like this, which is lakes of blood, pools of blood with this kind of thickened septations that look really bland. They have a few multinucleated giant cells, but no atypia, no abnormal tissue. This is an example of a aneurysmal bone cyst. And then we would know what we would want to do treatment-wise for that. If the pathology comes back like this, that same image with this picture changes my diagnosis. I'm now dealing with a giant cell tumor of bone. I've got sheets of multinucleated giant cells, and I notice that the background cells look just like the cells in the multinucleated giant cell. So this is a giant cell tumor of bone. And my treatment is going to vary differently from what this is. Now, this is abnormal cells that are pleomorphic. They're atypical. There's lots of vacuoles. There's lots of what I call ugliness on the slide. These quote unquote, maybe we would call these giant cells, but actually they're just atypical, multinucleated, abnormal, bizarre cells. This is a telangiectatic osteogenic sarcoma. And the reason it's important that you could have any one of those pathologies with that same imaging, but the treatment's very different. In the case of a giant cell tumor, aneurysmal bone cyst, you're probably going to do something like this: curate out the tumor, treat it with adjuvants. Those adjuvants in our case are usually high-speed burr and liquid nitrogen, and sometimes something called an argon beam, which is just a laser that we use on the bone. I stole it from the liver doctors because it happens to be present at the hospital. But if it's a telangiectatic osteogenic sarcoma, you're either doing some sort of amputative procedure or some sort of reconstructive procedure like this. And so those are very different management options. And of course, the telangiectatic osteosarcoma is going to get chemotherapy and other treatments as well. So now I want to shift gears and talk a little bit about metastatic disease, because I think this is a really important area that doesn't get enough discussion. As orthopedic surgeons, if I know I just spent some time talking about all these very interesting tumors like osteosarcoma and chondrosarcoma, but the reality of it is if you're a general practicing orthopedic surgeon, that's not what you're going to see on a day-to-day basis in your practice. What you're going to see is a lot of metastatic disease. And almost everybody who's taking care of patients in orthopedics are going to at some point in time come across a patient with metastatic disease and have to treat it, or at least refer it to the right person for treatment. So we talked earlier about the difference between these inactive and aggressive lesions. Once you've established that you're not dealing with an inactive lesion, that you're dealing with something aggressive, particularly something in an adult, it now requires a further workup. And we're going to talk a little bit about that. And this is important because you don't want to make the mistake of accidentally treating a sarcoma in an adult, which is definitely something that happens, treating it like a metastatic cancer, because you could end up either killing the patient because you've caused unnecessary spread of disease, or you've created a situation where they're requiring an amputation. And that's also not an ideal situation. So one of the early questions you have to ask yourself when you're talking about a lesion in the bone, particularly in an adult patient, and one that you don't have a specific answer to, is this a primary bone tumor or is this metastatic disease? Be thinking about primary bone tumors when their age is less than 50, no history of malignancy, no risk factors, and no evidence upon workup for other sites of involvement. So this is important. The workup is really, really important. So this is the algorithm that I still use to this day, that's used to help us work up a patient with a bone lesion, usually an adult, that we don't have an answer for, from a diagnostic answer for. First thing is a good history and physical. Please be careful about not getting stuck on a remote history of cancer. This happens a lot to people, and I've seen this in many legal cases that I've reviewed. Patient had a history from 20 years ago of breast cancer, so they presume the patient's got metastatic breast cancer. Don't make that assumption. Even a history of 2 years ago of having a history of cancer doesn't necessarily mean that what they're presenting with at that point in time is metastatic disease. So be cognizant of that, but still get a good history and physical. Lab work is helpful. The SPEP and UPEP are usually the most helpful tests. If you're going to do any testing for lab work, those two are the most helpful. And then in most cases, we're going to get CT, chest, abdomen, and pelvis. And if the CT, chest, abdomen, and pelvis does not give us an answer to what the origin of this tumor is, or doesn't show other sites of metastatic disease, then we're going to do a bone scan. I only will do a bone scan if my CT, chest, abdomen, pelvis is negative for any other sites of disease, because now I'm concerned that this is a primary bone tumor at that point in time, and I want to look for other sites of disease, or look to see if there's another spot that I can biopsy more easily. And then, of course, we're probably going to move to a biopsy, particularly if this workup above did not show any other sites of disease. So if there were no other sites of metastatic disease, no primary tumor was identified, you have to do a biopsy at that point in time before proceeding with any definitive management for this patient. That includes if they've got a fracture. So if somebody's got an actual fracture and you've got an unknown answer at this point, we can do what's called provisional fixation. You put a small provisional plate on the patient, do the biopsy at the time of you placing that plate, and then you close up and you wait for the pathology to come back. You don't do a definitive surgery until you know for sure what you're dealing with. So here's an example of a 56-year-old female that I treated several years ago, presents with this lesion in her distal tibia. She was initially treated by a different orthopedic surgeon, so I didn't see her till after her initial management. But the initial orthopedic treating surgeon thought that this was an active lesion. They were correct about that. It looks like some sort of active lesion. At that point in time, they appropriately ordered further imaging, because in the case of an active lytic lesion, we don't exactly know what's going on. They did do a workup with CT, chest, abdomen, pelvis, and did not see any evidence of further disease elsewhere. So they did the workup of it with an MRI, and they got these images back, and they thought, oh, this is just an aneurysmal bone cyst in an older patient. It's entirely possible, but it's also not possible. So they ended up doing a biopsy, which was a pretty aggressive biopsy because it was really a curettage of it. But they did a biopsy, and the biopsy came back with these spindle cells and abnormal pleomorphic cells and malignant bone formation taking place. And so this actually turned out to be a telangiectatic osteogenic sarcoma in a 56-year-old. So what do you do treatment-wise for somebody like that? Unfortunately, so first of all, chemo, and she's going to get neoadjuvant chemotherapy. And then in this case, we have to do a wide resection. It's the distal tibia. We don't have a lot of options, so we recommended to her an amputation. That's what she ultimately underwent. We don't love doing amputations, but sometimes there are places for where an amputation is an important place, an important role. And she's done well. She's been disease-free ever since. She's now 10 years out without recurrence of her disease. So for metastatic treatment, once you've identified a patient as having metastatic disease, so you've ruled out the rare but serious chance that somebody has a primary sarcoma of bone and they're over the age of 50, you then are in the category of, hey, this is metastatic disease. We know it is. Now what am I going to do? What's my treatment plan? So let's talk about that for a moment. So the main goals of treatment for patients with metastatic disease is restore function. Pain control is important. These patients often have a year or two or less to live. You want to try to prevent suffering, and you want to try to allow them to have as best function as they can. If you're doing surgery on them, you want them to be immediately weight-bearing following your surgery, if at all possible. We try not to do a surgery that would limit somebody's weight-bearing if they've got metastatic disease. We also try to do one surgery for one bone, if we can. Limit the trips to the operating room, limit the opportunities for there to be a revision surgery that comes up, although sometimes that can still happen. Can we prolong survival with our surgery? I think there's some debate about that. I personally think we can in the right patient population, but it doesn't always happen in this case. So the general principles of surgical care for these patients is that bone cement is a very cheap and friendly friend, a good friend for treatment of patients with metastatic disease. So I will very loosely use bone cement in a lot of cases. I'll put bone cement around a nail. I'll bone cement in my stemmed implant if I'm doing an arthroplasty. So I do like to use bone cement because cancer can't eat through that bone cement, so it can be an effective way to sort of support the bone. I use the least expensive implant that's available to me for these patients that's going to achieve the job that I want to achieve. So if it's an intramedullary nail, I use the least expensive intramedullary nail I can use. If it's an arthroplasty, I try to use the least expensive arthroplasty I can use. And that's because I don't, even in the setting of the United States where people think that we can willy-nilly throw in any implant that we want, the hospitals have very much come down on us on using high-cost implants in the wrong setting. And so we try very hard not to do that. I don't want to throw a $10,000 implant into a patient that's going to live for a year if I have a $1,000 or $500 implant to put in instead. Beware of fat embolization syndrome in these patients when you are putting long nails in. And know your patient. So we don't always have to operate on these patients. What we have to look at is what their life expectancy is and whether my surgery or the surgery you're thinking about doing is going to improve their quality of life for whatever remaining time they have. So if they have less than 3 months to live for the upper extremity, I try to avoid surgery. Same for the lower extremity at 6 weeks and for the spine at 6 months. And that's because oftentimes the patients don't have time to recover from your surgery in that period of time if they've got less than, let's say, 6 weeks to live for a lower extremity. And you can consider non-operative management in those cases. So in the case of a lower extremity, I might put the patient on crutches or a rolling walker, or even place them on bed care, transfer care, if I know their life expectancy is very limited. For the upper extremity, you can give them a sling. You don't necessarily have to operate on everything. So be aware of that. Think about your patient population carefully in these circumstances. So this is an example of a patient with multiple myeloma. Unfortunately, towards the end of their treatment, they were running out of treatment options. So in this case, we did an intramedullary nail fixation. They lived for an additional 5 months and then passed away, but did reasonably well following our surgery. So you can do something very simple. You don't have to do something complex, and this can provide the support the patient needs to keep doing the things that they do in life. That's the OR reminding me that I've got the OR. Sorry. And so in the patients with metastatic disease, this is really important. You have to coordinate the care that you do with them with your medical oncology teams and your radiation oncology teams. If you're not a good communicator, and there are people out there to just know they're not good communicators, don't take care of metastatic patients. Pass them on to your partners who might be better communicators, because this does require a lot of communication with the medical oncology team and the radiation oncology teams. I try to get these patients on chemo, back on their chemo quickly within 2 weeks. I try to get them radiation treatment within 2 or 3 weeks of the surgery. And I try to make them weight bearers tolerated as quick as feasible so that they can actually make it to their appointments to get back on their chemo and back on their treatments. So this is very important for a metastatic population. I'm now going to transition for the last few minutes and hopefully leave a little bit of time for questions on creative ways to treat these bone defects or tumors. We talked a little bit about some of the things we do. I've used allografts when I have them available and when they are appropriate. I obviously use implants when I have them available and they're appropriate. And I use bone transport or bone transition, so I can take the fibula and move it around if I can find a spot for it to go. We're going to talk a little bit more about that. So in osteosarcoma or other major bad tumors, this is an osteosarcoma of a teenager, you don't always have to do a big crazy implant. If you can get away with sparing the bone and doing some other type of treatment, there are modalities out there. There's actually some data out there that even these allografts are not necessarily needed if you have a good free fibula. And so in this case, I happen to use the Campanacci approach, moving forward, where you put the allograft, situate the allograft, the free fibula, vascularized fibula in the allograft. But you actually can get away nowadays with actually out using the allograft at all and just doing a free fibula. And if you do that approach, I wouldn't use just one plate. I would definitely double plate this so that you have better fixation, because you're going to be waiting a long time for that fibula to hypertrophy and for that fibula to union to the native bone. But it can happen, and you don't necessarily need to use an allograft. I did in this case, but there are cases out there of my colleagues who've started using no allograft, just the free fibula with good plate fixation. So that's one approach. There's another approach that's out there, which I'm sure you've heard about, which is bone transport. Now, the bone transport, there are these intramedullary devices that do bone transport. They are quite expensive. They are quite, they're a little bit more complicated to use. But external fixers, which have been around in orthopedics for, since the beginning of orthopedics for the most part, are relatively good ways to still do bone transport in some situations. Now, the downsides are you've got these pins sticking out of the bone. The patients are going to get pin site infections and things like that throughout the course of this, but you can actually do some pretty amazing things with bone transport. And the nice thing is that this implant, this external fixer, can be reused in a different patient if need be. And these pins can be sterilized and reused at a later point in time as well. And I've seen that done both here and elsewhere in the world. And so with bone transport, you can actually, particularly in a young person that's got the potential, create new bone in a situation where the bone was either not present or was not healthy, and ultimately end up with a very good outcome, as you can see in this patient example. So bone transport is something that can be done successfully and can give a good result if done correctly. It is a technically challenging thing to do. So I would say that if you're interested in bone transport, you probably need to have somebody at your institution or around that that has done this elsewhere and has trained in it and knows how to do it, because there are some nuances to making sure the transport happens correctly and that the patient has a good outcome as a result. I have not personally done this, but I think it's something that is a viable option and something that should be thought about and considered in patients with high-grade osteosarcomas in their limbs, but you don't have a good reconstructive option for them for whatever reason. Material's not available, or the patient it's just a complicated situation. The folks in Japan, in Kanazawa, Japan, have perfected this technique where they actually cut the bone above where the tumor is. They scoop out the tumor as best they can. So they do this kind of like curettage, intramedullary curettage or tumoral curettage. And then they actually dump the tumor or the part of the limb into a vat of liquid nitrogen. And then they put that bone back in the patient, believe it or not. And then they fix it with fixation points with either intramedullary nails or plates and rods. And they've actually had a relatively good success rate. I would say their local recurrence rates are slightly higher than what ours are here in the United States. Ours in the United States are probably somewhere around 4 or 5%, and they get somewhere around 8 to 12%. But I have to say, for a technique that actually saves the patient's native bone, A 12% recurrence rate is pretty impressive for what they're doing. And so I think it's something to consider. They do have complications in association with this. Fractures can happen in the treated bone, and resorption of the treated bone can also happen. So very similar to other allografts, but at least the bone is the patient's native bone. You didn't have to order expensive allografts. You didn't have to use a big expensive metal implant. I always have to mention rotation plasty because I think it's something important to mention, but I also need to talk about it in two stages. Rotation plasty is a great alternative surgery for a young person who doesn't have a great reconstructive option for either a distal femoral or proximal tibial sarcoma. But as one patient who I recently was talking about this procedure with pointed out to me, and it's a fair, valid point, this is still an amputation. You're still taking the patient and turning them into an amputee. You're turning them into a below knee amputee as opposed to an above knee amputee, but at the end of the day, they still have to spend the rest of their life using a prosthetic. And one thing that's really important in the case of the rotation plasty is the prosthetist has to be skilled enough to create a prosthetic that's going to work for this now foot that's going to become their residual limb. And so that only works if you have a good prosthetic team that can make that happen. That's not always going to be the case in every part of the world and everywhere you're working. So I think it's important to recognize whether this is a feasible option for the patient or not. I'm going to stop, hopefully, and end there. That's my son. And I thank you all for listening. And I hope it was somewhat educational. And I'm happy to take any questions that you might have or discussion points that you'd like to talk about.
Thank you so much, Dr. Tyler. We do have a lot of questions. The first question is, can the fibula truly support normal activities like the humerus? And what are the outcomes or after effects of the surgery?
Right. So the big problem is that the fibula itself in terms of bone is great. It's growing, it's doing its job. Here's the problem. When we do that surgery and take her proximal humerus away, we detach the deltoid, we detach her rotator cuff, we detach her pecs, and we try our best to reattach those to the fibula. But the reality of it is those muscles never work the same once you've detached them from their native bone. And so we never get a kid that's, at least we haven't at this point with this particular procedure, have a kid that's done this. But we do have kids that get to like here to 90 degrees or to 85 degrees of abduction, and they're functional. So it's not perfect. So it's a very good point. They don't return to normal function, but they have an arm that they can use, and they can extend and use the elbow normally and their hand normally, and they can hold their arm in space. And that's what we're hoping for.
And we have one of our PGY4 residents from the University Hospital of La Paix. So he has a question in low resource settings. We don't have MRIs or CT scan.
Okay.
So we mostly rely on our clinical skills to diagnose and manage those type of patients.
Yeah.
With that in mind, his question is there a way to diagnose osteochondroma based purely on clinical examination?
Totally. So just totally, yes. Yeah. Okay. That's a great question. So an osteochondroma, just with no imaging at all. The answer is probably yes. So it's if you've got a young person who presents to you and they've got a very firm bony mass that's well fixed, and they tell you it's been there a while. It's been hanging out there for the last 5 years or 3 years or 2 years, and it hasn't changed much in relation to them. It's kind of growing with them. You can clinically diagnose an osteochondroma. What I would recommend in that circumstance is that you're going to do kind of serial follow-up on that patient. You're going to see them again 6 weeks later or 3 months later and make sure that that osteochondroma, that firm fixed bony mass, is not changing in any dramatic way. So the answer is yes. I have to admit the vast majority of patients I take care of with osteochondromas, I do get plain x-rays. I don't get CTs and MRIs. I almost never get CT and MRI and osteochondromas because they're benign tumors and you can diagnose them on x-ray. You shouldn't need a CT scan or an MRI to diagnose them. So I'm actually frustrated when the patient shows up in my office and somebody's gotten some $10,000 workup with MRIs and CT scans for like a benign osteochondroma. So you shouldn't need fancy imaging to diagnose an osteochondroma. I tend to get x-rays because they're available to me, but that doesn't have to be the case.
And is the management of osteochondromas in long bones similar to that of short bones?
Yeah, generally, yes. So if I've got one in the scapula, let's say, and as long as it's not causing the patient major concerns or problems, I still just clinically follow that. I don't necessarily operate or remove those. People talk about the shorter bones, like for instance, the scapula or the pelvis. having a higher risk of turning into cancer. That risk is still well under 1% lifetime risk, well under. It's probably 1 in 1 million. And so I don't think that that justifies us doing surgery on these patients just because there's this very, very small risk. So the answer is that the management should pretty much be the same. If they're not symptomatic in any major way, you don't have to operate on it.
And if a bone tumor is excised and humeral reconstruction or fibrillization is performed,
Yeah.
what would be the post-operative management algorithm?
Yeah. So that it's a tricky one. So for that girl, that gal of the example of the proximal humerus, we left her in a abduction brace. So basically, she's got a little pillow with her arm sort of at about 45 degrees with internal rotation, and we left her there for about 3 months. So we don't let her use that arm for the first 3 months. Essentially, it's in a sling with a pillow for 3 months. After 3 months, because I want things to scar in intentionally, I let her use her elbow. I let her come out of the sling and rotate, range the elbow pretty much within the first 4 weeks. I still wait about 4 weeks before I let that elbow really get moving because of the fact that the fixation needs some time to heal. But then we get that elbow moving, we get the wrist moving, we get the hand moving, but we don't let that shoulder move for about 3 months. And then after 3 months, we start Codman's pendulums and we start moving that arm as much as we can. And we start working with them on a therapy protocol that lets them slowly start using that arm more and more. So it's a process.
And
Yeah.
if operative treatment fails, what is the cause and what steps should be taken?
Oh gosh, for the fibula, if the operative treatment fails, you're in trouble. So, I mean, anytime operative treatment fails, you got a problem on your hands. So it depends on what the reason for the failure is. If it was a local recurrence, obviously that's a big problem. And oftentimes local recurrences end up needing amputations and other types of procedures like that. If the local failure is because of a failure of fixation, the bone didn't heal correctly to the native bone, or you have instability, there are things you can do in that situation. So if it's a bone healing issue, I will go in and try and do bone grafting before I give up on the patient. If it's an instability at the shoulder issue, I might try to do with my plastic surgery team a muscle transfer to try to provide stability to the area. So those are some things we can do that are easy treatments. If it's an infection or something bad like that, those are also really challenging. Often you have to take everything out and do kind of crazy washouts and hopefully try to reconstruct. But even sometimes those end up being really difficult cases to deal with, because once you've got an infection, oftentimes you can't get rid of the infection. So those are challenging. And we sometimes end up with an amputation in those situations, unfortunately.